Now let's talk about spore-forming bacteria, then continue with virulence factors, and then finish this video by discussing bacterial drug resistance. Firstly, spore-forming bacteria represent a classic survival strategy tested repeatedly by examiners because it explains both environmental persistence and infection control failures. Certain gram-positive organisms, specifically Bacillus and Clostridium species, can form endospores when nutrients are depleted. These spores are metabolically inactive and extremely resistant to heat, desiccation, radiation, and many chemical disinfectants. The resistance is largely due to the spore core, which contains dipicolinic acid complexed with calcium. This stabilizes DNA and proteins and is the key reason spores survive boiling and routine cleaning. Because of this, standard disinfection is insufficient, and sterilization requires autoclaving, steam under pressure at 121 degrees Celsius for 15 minutes at 15 psi, a detail frequently embedded in infection control or hospital-based STEM questions. Hydrogen peroxide and iodine-based agents are also sporicidal and may appear as answer choices when autoclaving is unavailable. High-yield examples include Bacillus anthracis causing anthrax with black escar and mediastinal widening, Bacillus cereus causing reheated rice food poisoning, Clostridium botulinum causing descending flaccid paralysis, Clostridiades difficile causing pseudomembranous colitis after antibiotic use, Clostridium perfringens causing gas gangrene with myonecrosis and crepitus, and Clostridium tetani causing spastic paralysis via inhibition of inhibitory neurotransmitters. A common testing clue is that spores survive routine disinfectants and require autoclaving to eradicate Bacillus and Clostridium species. Bacterial virulence factors are mechanisms that allow organisms to evade host defenses and establish infection, and they are often tested by asking which factor explains immune evasion or severe disease. Capsular polysaccharides are among the most important virulence determinants. These capsules are highly charged and hydrophilic, forming a physical barrier that prevents phagocytosis and protects against complement-mediated lysis. Encapsulated organisms are more virulent, and questions often emphasize increased susceptibility in patients with impaired splenic function because the spleen is critical for clearing encapsulated bacteria via opsonization. Loss of capsule typically results in a dramatic decrease in virulence, a concept frequently tested through mutant strain comparisons. Protein A is a specific virulence factor expressed by Staphylococcus aureus and is a favorite target for mechanism-based questions. Protein A binds to the Fc region of IgG, effectively flipping antibodies backward so that phagocytes cannot recognize them. This prevents opsonization and subsequent phagocytosis, allowing the organism to persist despite an intact humoral immune response. Questions may describe normal antibody levels but impaired clearance of gram-positive cocci in clusters, pointing toward this mechanism. IgA protease is an enzyme that facilitates colonization of mucosal surfaces by cleaving secretory IgA, the primary immunoglobulin responsible for mucosal immunity. This allows bacteria to adhere to respiratory or nasopharyngeal epithelium without being neutralized. High-yield organisms that produce IgA protease include Streptococcus pneumoniae, Haemophilus influenza type B, and Neisseria species. Board questions often link recurrent respiratory infections or meningitis with organisms that bypass mucosal immunity through IgA cleavage. M protein is a major virulence factor of group A streptococci and functions by preventing phagocytosis. Beyond immune evasion, it has significant autoimmune implications. The protein shares sequence homology with human cardiac myosin, leading to molecular mimicry. This cross-reactivity underlies the pathogenesis of acute rheumatic fever following streptococcal pharyngitis, a classic concept tested through delayed cardiac, joint, or neurologic complications occurring weeks after an untreated throat infection. Antibiotic resistance mechanisms are consistently tested by asking how a drug failed despite appropriate dosing or which molecular change explains resistance. Enzymatic inactivation is a major mechanism where bacteria produce enzymes that destroy or chemically alter antibiotics. Drug cleavage is seen with beta-lactamases that hydrolyze the beta-lactam ring, rendering penicillin G, penicillin V, penicillin A-sensitive penicillins, cephalosporins, and even carbapenems ineffective depending on the enzyme. Drug modification is another enzymatic strategy, particularly relevant for aminoglycosides and chloramphenicol, where acetylation or phosphorylation prevents the drug from binding its target. Resistance can also occur through increased efflux or decreased uptake, where bacteria either pump the drug out or reduce porin channels to prevent entry. This mechanism is commonly associated with tetracyclines, sulfonamides, and fluoroquinolones, and is often hinted at by gram-negative organisms with altered outer membrane permeability. Drug target modification is another heavily tested category and involves structural changes to the antibiotic's binding site. Ribosomal RNA modification confers resistance to drugs like linezolid and macrolides by preventing proper binding to the ribosome. Enzyme alteration can affect targets of penicillinase-resistant penicillins and cephalosporins, while changes in metabolic enzymes can cause resistance to sulfonamides. Fluoroquinolone resistance commonly arises from mutations in DNA gyrase or topoisomerase 4. Finally, cell wall target modification is classically tested with vancomycin resistance, where alteration of the diala-diala terminus to diala-dilac reduces drug binding, a mechanism frequently linked to enterococcal infections and treatment failure scenarios. To go into more detail now, antibiotic resistance mechanisms tested on boards are not random lists. They are repeatedly framed as why did the drug fail despite correct choice and dose? And the answer is almost always a specific molecular adaptation. One of the most frequently tested mechanisms is enzymatic inactivation, particularly beta-lactamase production. Beta-lactamases cleave the beta-lactam ring, rendering penicillin G, penicillin V, and penicillinase-sensitive penicillins ineffective. Extended-spectrum beta-lactamases can inactivate many cephalosporins, and carbapenemases can inactivate carbapenems, which is often tested in hospital-acquired infections with multi-drug-resistant gram-negative rods. A related enzymatic mechanism is drug modification, where bacteria chemically alter antibiotics so they cannot bind their targets. Aminoglycoside resistance commonly occurs through acetylation, phosphorylation, or adenylation of the drug, preventing binding to the 30S ribosomal subunit. Chloramphenicol resistance is classically due to acetyltransferase production, a detail frequently tested when a broad-spectrum drug fails despite intracellular penetration. Another major category is decreased intracellular drug concentration, achieved either by increased efflux pumps or decreased uptake through porin loss. Tetracycline resistance is commonly due to efflux pumps that actively expel the drug from the bacterial cell, a classic mechanism emphasized in STEM questions involving acne or atypical infections. Fluoroquinolone resistance can involve efflux pumps as well, but is more often tested through mutations in DNA gyrase or topoisomerase 4. However, efflux remains a common distractor answer. Sulfonamide resistance may also involve decreased uptake, particularly when bacteria bypass the folate pathway entirely or reduce drug entry, leading to failure of combination therapy. Drug target modification is one of the highest yield mechanisms and appears repeatedly across systems. Alteration of penicillin-binding proteins is central to resistance against beta-lactams. Penicillinase-resistant penicillins and cephalosporins can fail when PBPs are structurally altered, leading to decreased drug affinity despite intact beta-lactam rings. This concept is frequently tested in gram-positive infections that persist despite appropriate beta-lactam therapy. Ribosomal target modification is another classic theme. Macrolide resistance occurs through methylation of 23S rRNA, preventing binding to the 50S ribosomal subunit. Linezolid resistance also arises from mutations in the ribosomal RNA, which is often tested in severe gram-positive infections where this drug is used as a last-line agent. Enzymatic alteration of metabolic pathways is a key resistance mechanism for sulfonamides. Bacteria may mutate dihydropteroate synthase or acquire an alternative enzyme with reduced affinity for the drug, allowing folate synthesis to continue despite therapy. This is often tested in urinary tract or gastrointestinal infection vignettes where sulfonamides initially worked but later failed. Fluoroquinolone resistance is among the most commonly tested and almost always points to mutations in DNA gyrase, topoisomerase 2, or topoisomerase 4. Board questions often describe stepwise resistance developing after repeated exposure, highlighting chromosomal mutations rather than plasmid transfer. The STEM may include a clue such as failure of ciprofloxacin in a gram-negative infection or levofloxacin in pneumonia. Vancomycin resistance is a classic cell wall-based mechanism and is nearly always tested mechanistically. Resistance occurs when bacteria alter the peptidoglycan terminus from diala-diala to diala-dilac, dramatically reducing vancomycin binding affinity. This mechanism is strongly associated with enterococcal infections and is commonly framed as persistent bacteremia despite vancomycin therapy. Finally, resistance through altered membrane permeability is often tested in gram-negative organisms. Loss or mutation of porin channels reduces entry of beta-lactams, carbapenems, and fluoroquinolones. This is frequently paired with beta-lactamase production in questions to emphasize synergistic resistance, where reduced entry plus enzymatic destruction makes organisms exceptionally difficult to treat. Across these questions, examiners consistently reward recognition of the specific molecular change, enzyme production, efflux pump activation, ribosomal mutation, altered PBPs, or modified cell wall targets, rather than simple recall of which drug covers which organism. Together, these concepts explain why certain organisms persist despite host immunity and why specific antibiotics fail, and examiners frequently integrate them into clinical vignettes that require understanding mechanism rather than memorization.